So just as a little bit of background, I know all of you guys know this already, but this is a 22q meeting, so I just want to make sure we're all on the same page. 22q11.2 deletion syndrome goes by many different names: velocardiofacial syndrome, DeGeorge syndrome, and many others. But we really like to try to use the common terminology because this sometimes confuses a lot of people, and people think of these things as different and separate disorders when they're all caused by the same gene mutation, which is a missing piece on the long arm of chromosome 22. The prevalence is estimated in 1 to 2 to 4,000 live births, although it probably may be more common than that, because as we know, there are milder cases that haven't been picked up, as well as some prenatal studies that suggest it may be even as common as 1 in 1,000. And so it's the most common microdeletion syndrome in humans, and the second most common genetic syndrome after Down syndrome. Most of these deletions are de novo or spontaneous or new, meaning not inherited, although for an individual who has the deletion, they have a 50% chance of passing that along to their offspring in an autosomal dominant fashion. And I'm not going to spend a lot of time on the medical manifestations. I'll refer you to our educational video that is on the website page that Tony mentioned. But it's really just to kind of, as a general kind of exposure here, is that the genes that are deleted in the 22q region really affect embryological development. So development that leads to the structures in the face, in the midline structures here in the neck, and even into the thorax. So that's the reason we see some of these very commonly affected organ systems. So in the heart, we see some structural heart defects, like tetralogy of Fallot. We can have palate dysfunction, whether it's a cleft palate, a submucous cleft palate, or just velopharyngeal insufficiency, or the fact that the muscles in the pharynx don't function as well. And often a telltale sign on physical exam of a submucous cleft palate is something like a bifid uvula. This is the little thing that hangs in the back of the throat that usually you see. It looks like a little punching bag, and here this is split in the middle. And then, of course, because the thymus can be affected, we can see immunodeficiency, and the hormone systems, the endocrine dysfunction, we see as low calcium levels when the parathyroids that surround the thyroid are affected, as well as low thyroid levels, or sometimes high thyroid levels, but more often low because of these effects from early on in embryology. So the other reason the slide is here is because I just want to mention that I think we're pretty good at picking up 22q when, you know, there's congenital heart disease or some of these other things, but we're probably not as good as identifying and also being able to treat accurately some of the psychiatric manifestations that we see with the deletion. So here is data from the 22q International Consortium that lists the pooled prevalence rate of studies from across the world of how common things are. So attention deficit hyperactivity disorder, in the literature, it's been reported to occur about 30 to 50% of individuals, of children and adolescents, and it's generally more the inattentive or easily distracted type, although many of our children are also impulsive. And the pooled prevalence rate from the consortium is 37%. Anxiety disorders, which I'll be talking quite a bit about, are also quite common, 30 to 60% in the literature, and then from the consortium about 36%, with kind of the highest one being here specific phobias. But we also see separation anxiety occurring, social phobia, obsessive compulsive, and generalized anxiety also being common. And then for mood disorders, not as high prevalence as ADHD and anxiety, and actually in childhood not very much increased compared to the general population, although in adolescence it is quite a bit higher. So as I mentioned, despite this known risk that we should be looking for ADHD, anxiety, et cetera, psychiatric conditions are still under-identified and under-treated in children who have 22q. So in looking at the children that have come into our studies who are coming in for research, so not coming with a complaint or a clinical reason, just by nature of the battery that we do, we get a sense of if they're having anxiety symptoms or not, and other things as well. And we find that about 50% of children have current anxiety symptoms, but only 20% of them have been previously diagnosed. And of course, there could be many reasons for that, whether, you know, practitioners aren't asking about it, or whether it doesn't seem to be a problem yet, or it's just, you know, checking in that point of time. But that's a big discrepancy here, and I think we can do better. We're not the only ones who have reported this. So 2 other groups have said anywhere from a quarter to 50% of children with symptoms actually receive the mental health care treatment or medications that could really help them. So why is anxiety underidentified in children? Well, first of all, because there's not just one type of anxiety. So as I mentioned, separation anxiety looks very different from a specific phobia or fear, which is also very different from the way an obsessive compulsive disorder presents. And some symptoms may not look like anxiety, and children aren't always going to say, I'm feeling anxious right now. Instead, what you're going to see is maybe some oppositional behaviors, or maybe they'll be avoidant about things and they don't want to try new things. Sometimes this overlaps with ADHD type symptoms, so they look distracted because they're too busy worrying about what's going to happen, when they go to their next class or otherwise. They may just kind of come up as overreacting, needing a lot of reassurance. All of these things are fairly nonspecific and hard to identify as, haha, this must be anxiety. But we kind of want to take the behavior in the full context and try to understand what might be driving some of these difficulties. Of course, other things sometimes you see are somatic complaints like headaches or stomach aches. And of course, that's difficult for some of our kids who have organic problems with reflux or migraines. So it's often hard to tease this apart. And so you've seen this slide before from me, but anxiety, we know, affects real-world functioning for our children with 22q. So when I talk about real-world functioning, I'll also call that adaptive functioning. And what that means are the skills that you need to become an independent being and function well in your community, which is what we want ultimately for all of our children as they grow up. And this can vary by age in terms of the appropriate expectations for what that may be. But that includes things like self-care, getting dressed in the morning, picking your clothes, choosing something appropriate to wear, navigating in the community, whether that's riding a bus to school, or as an adult being able to drive a car or navigate public transportation, being able to order food in a restaurant. These are all skills that are important for us to get by every single day. And what we've seen from children that have come through ages 7 to 14 through Tony studies in the past is that in typically developing children, we see this expected relationship between IQ and adaptive functioning. So the higher the IQ, generally speaking, the better that individual is as being able to apply those in real life, everyday situations. And so that's what we see here in our typical control group. And then in children with 22q, we don't see this relationship at all. There's no relationship here between the two. And instead what we see is that anxiety is strongly related to in children with 22q, their adaptive functioning. So the children who have higher anxiety are having a harder time in their everyday living skills. So something is impairing them from being able to kind of use the full potential of their cognitive skills. And what I can show you here is some of the data that I've had from my study, which gets into a little bit of a younger age group but overlaps. So children ages 4 to 11, when I've split them by younger and older cohorts, what we see here in terms of IQ is in the younger kids, we're seeing more of this typical pattern here with the relationship between IQ and adaptive functioning. And here, remember, this is the 22q group that didn't have this relationship. And this, in the older kids, is very similar to what we see in that older 22q group too. This is not significant, the relationship between IQ and adaptive functioning here. And then when we look at anxiety, again, in the 22q group, we're seeing, the older group, we're seeing higher anxiety, lower adaptive functioning. These are a bit different measures we use, but very similar. And then no relationship necessarily in the younger group, the kids ages 4 to 7. And so while this isn't something longitudinal, following children over time, I mean, this is all just cross-sectional. These are all kids at the same time. I think one of the important implications here for me is that I think if we can be more aggressive about identifying or treating anxiety perhaps in the younger children when it's not so impairing when they have it, perhaps by the time they're in this older age group, maybe this relationship will look very different and not have such a large effect on the adaptive functioning, and that we can change outcomes and make real-world functioning better for these kids. So with that in mind, that was one of the reasons I did the current study. And I think one of the really important factors, especially for these young children, is looking at what we can do to shape behavior as parents. This makes intuitive sense. Parenting is something that helps modify behavior, and we rely on our parents to teach us things like how to develop independent skills. And then in the literature, the non-22q literature, we know that parenting can mitigate the impact of mental health risk. And this is important for not just 22q families, but all families, both typical and delayed. And for me, I think this also is important because I think there's an impact to affect treatment later on for these kids. So many children with 22q, by the time they're in mid or late adolescence, are on many different psychotropic medications, and some of them have significant side effects. So if there are ways we can kind of shift earlier to teaching better coping skills and prevent the need for so much intervention later, I think that can be a real benefit of this work. And so I just want to bring a quote that was put in one of the Velocardiofacial Syndrome Education Foundation, when this was around, newsletter that I think is a really good point to stress. Well, the difference between what can I do to help my child with stress and anxiety versus what can I do to assist my child's effort to cope with stress and anxiety. So here the focus is really on what can the adult do, and here it's the adult as a support, but you're really trying to garner those skills in the child to be able to do without you at some point. And so we know parents can make a big difference and make a big impact on reducing anxiety in their children. And of course, we've seen here the relationship in those prior slides between child anxiety and adaptive skills. And then we know from the literature there are strong relationships between parental factors and child anxiety, as well as parent factors and independent living skills. And so we know the home environment with parent-child relationship, it is a two-way street. It doesn't just work one way. So of course, some of our children are a little bit more prone to anxiety and anxious behaviors, so that can affect how we parent them, how we may reinforce certain skills or encourage other skills like bravery and otherwise. And then we know that parenting styles can support healthy behaviors. What I focused on for the KL2 study was a type of parenting called parental psychological control. I may also call it PPC for short. It's also called intrusiveness or overprotection, or kind of that helicopter parenting, this idea of just stepping in too soon to help the child, but not necessarily allow them to develop mastery over a situation. And the formal definition is the management of child behavior through the manipulation of their emotions, expectations, and independence. So there's a focus on that developing independence. And it's an exaggeration of the natural tendency we all have to protect our children. We see this in some medically fragile children, children with developmental delays, and it can really impact the development of independence as well as autonomy. And we know also from the literature that this type of behavior is also related to child anxiety. Oftentimes, obviously not causing it, but sometimes reinforcing natural tendencies that children have to kind of avoid certain situations. So here's an example of what we have here. So Amy has separation anxiety. She has a difficult time getting dropped off at school in the morning. So her mom decides to stay home at school and volunteer as a classroom aide to help ease the transition. She ends up staying for a few hours because she notices that Amy needs a little extra help with classwork, and by the end of the morning, she's doing hand-over-hand guidance to help her with her handwriting. Amy's mother feels that Amy needs her assistance or she'll fall further behind, so she starts going on a daily basis. So this is totally something that makes sense and feels intuitive to do. And I just point this out because sometimes it is so easy to fall into these things because we're working in our child's best interest. And it's what's right in the moment. It's totally what's right in the moment. But we also have to do what's right in the moment with the end goal of what's going to be right also for the next 10 years, for the 5 years, and otherwise. And that is not an easy thing to do. Not when you don't feel like you have good supports at school, or that your child will be well taken care of from whatever sort of services they're getting, which is also often a problem. So in this study, we were looking at parent PPC in families with 22q, as well as families that did not have that. And we were investigating also those relationships, so those boxes I showed you before between anxiety and adaptive outcomes. And our goal was to enlist 60 parent-child dyads, the children between the ages of 4 to 11, 30 with 22q and 30 with typical development. And thank you so much for everyone that's in the room here, because you were able to help us meet our recruitment goals, and you'll see this in the next slide. These are the different different methods that we used for collecting all of the constructs here, parental control, and what I'll be reporting on are just the ones in black today for the purpose of time. But we also have some tasks that we had you do in videotape that will also be looking at some of the parental psychological control from coded behaviors. But this is the PSDQ that many of you filled out just on self-reported behaviors. And then adaptive functioning filled out by the parent about their child's adaptive skills, and then also the Spence Children's Anxiety Scale filled out by the parent about the child's anxiety. And so we did great with recruitment, 33 in each group. No difference in age for the two groups, and no difference in gender distribution. What we see in the 22Q group is a lower IQ than the control group, which is expected, and this is in the range that we would expect, and then also lower adaptive skills compared to the control group, and then anxiety being higher, and this mean score is in the elevated range. So looking at differences here, it didn't come out, but basically there were no differences in all of these different self-reported behaviors. So these are your standard types of parenting: authoritative, authoritarian, and permissive, and these were not different between the two groups. And the only things that came up as being a bit higher in the 22Q families versus the TD was parental psychological control, and specifically the overprotective type of control. So looking at those relationships, when we do a statistical model where we put in predictors, so IQ, parental control, group, child sex, child's age, and socioeconomic status, those things all together explain about 34% of the variance for outcome of child anxiety. And when we see significantly predicting child anxiety is the parental control being in the different groups, and also different relationships in the 22Q group versus the TD group. And you see that here graphically. So no relationship here with parental control and anxiety, but here in the 22Q group, we're seeing higher parental control in children who have higher anxiety. And then looking at adaptive functioning as a different, and how these things might explain it. For the group as a whole, when we put everyone together, we actually don't see a relationship of parental control, but let me tell you a little bit more about that next. IQ and group are significantly explaining the adaptive functioning. And so that's what we see here, flat lines basically for the pink group as well as the blue group. But again, when we split by age, we see some interesting differences, basically opposite relationships going on here. So for the higher the parental control, the lower the adaptive functioning here in this older group, but actually the opposite here in the younger group. So the parents are really helping to support these children when they're younger, and that's helping them at that point. But here we're seeing some effects on adaptive functioning. So in summary, 22Q dyads have higher levels of parental psychological control. This is similar to what we see in other families that have children with delays, and it's particularly this overprotective type of parenting, not rejection, not critical. In children with 22Q, we see higher parental control being related to child anxiety, and perhaps that may affect or should guide different sorts of interventions that we could use to kind of shape children's behavior earlier on. We see it's negatively related to adaptive functioning just in the older children, not in the younger ones, and perhaps this is limiting autonomy and the development of independent living skills. So the limitations of this study are clearly that it's a small sample size. We didn't have a lot of children and parents in, and it's observational, meaning we're not really doing a manipulation and seeing what the difference might be. It's really just taking one point in time and trying to make some inferences about where to go next. There was a wide age range, although for me it was very exciting to be able to start looking some younger kids and see what's going on. And then again, what I've told you about today is just all from parent report, although we do have some of the coded behaviors that we will look for warmth, sensitivity, and structure as well to see how those things can help bolster adaptive functioning. And so as we talk about maintaining balance, I think it's important for us to remember that this is a natural response for us to do these things to care for our children, especially when we have real challenges to deal with. But with time, we also have to need to build skills to develop independence and then vary the amount of support we have. So it's not going to be something static. It's something that changes over time. And when we have more difficult behaviors, we're going to provide more support. And then when things are going pretty well, we're going to try to pull back a little bit more. And that's hard to do sometimes. I know for myself, trying to get out of the house in the morning with 2 young kids it's easier for me to kind of pack the bags and get us all in the car. But when there are times when it might be easier to be able to give them the extra time to do it themselves so that I don't have to remember it all for them, that's going to be more helpful for us in the long run. And so the influence of the home environment, this is very important. So, children learn from us, and we're their best teachers. We're with them all the time, more than any therapist or other person. So children learn our behaviors from watching us. It includes how do we cope with stress, so we can start to model for them what to do when things get hard, how we handle tough situations, finding things that make us feel good about ourselves, and for them, finding things that make them feel good about themselves. What can they be proud of? What's their thing? What makes them who they are? Also modeling how to take good care of yourself, whether that means, physically or getting enough sleep or emotional support from family or friends. Things like that are also really important that we don't just think about teaching to our kids. Also modeling how to respond to disappointment, and of course treating people with respect and how we value our relationships. So with the next couple slides, I just wanted to talk about a couple of parent-child interventions for anxiety that have shown some promising work in the literature. I mean, there are of course, many other types, but these are 2 I just wanted to highlight. The first is parent-child interaction therapy that many of you may have heard of, and then another one is a treatment study by Dr. Rapay. So PCIT is a specific type of coached therapy that is, generally speaking, actually originally designed for oppositional behaviors, and it works quite well for those, but it's been adapted for anxiety as well. So it targets the parent-child relationship and attachment, and it first builds on a part called child-directed interaction and then parent-directed interaction. So the PDI part is then when you start focusing on following rules and kind of discipline and other things like that. But it has to be done first in a way where the children understand where the playing field is, and you've kind of got enough in your piggy bank to start taking away from it and having them have to respond to consequences. And so through this, parents can help shape their children's behavior. So of course, an example would be not reinforcing avoidance of things. And there's 2 types that have been published through the Pincus group, Bravery Directed Interaction and the CALM program. This is really focusing on being brave, and then the CALM program is actually working on helping parents to do a little bit of exposure to their children. So putting them in slightly uncomfortable situations, but then showing them, look, it was okay, you thought it was gonna be like this, but you made it through it, and you can do it again next time. So it's not flooding, like you're putting them in these horrible situations, but just little baby steps each time. And that sense of, I did it and I mastered it, goes a long way and can be applied every day. And this was impressive to me. I mean, these were very small pilot studies, so it's not like they've done this on a lot of kids. But of the studies that I was able to see that were published, 80% of the children who had gone through this bravery-directed PCIT no longer had a separation anxiety diagnosis after this was a 12-week program. And they followed it out to 12 months, and they saw that this had lasting effects, which is pretty good. I mean, that's very good. And then the other treatment study I wanted to mention is taking children who didn't have an anxiety disorder, but they were at increased risk for anxiety because of their temperamental style, which is probably also related to how their central nervous system is kind of wired. So those who have behavioral inhibition or withdrawal, so like extreme shyness is kind of, the kind of a extreme example of that, those children tend to be at higher risk for developing an anxiety disorder. And so he took these high-risk children, and then he had their parents learn how to reduce anxiety symptoms in them. So part of that involved talking about what we can do to not maintain anxiety, and also restructuring how children think about the environment and about challenges. And then this did really well too, where, so again, a lot of these children didn't have anxiety, and so those who went through the program, that group had much fewer rates of anxiety disorders developing versus the ones that didn't. And what was interesting was that they were still behaviorally inhibited. They still had those tendencies to kind of be shy and withdrawn, but it didn't translate into higher risk for an anxiety disorder. So they were still, having those tendencies, but they knew how to cope with them or how to address them. And so that's pretty great. So I'm wrapping up now with just some tips for healthy coping. Having realistic expectations is very important. Modeling good coping strategies and problem solving is important as well. How do we reduce stress for everyone involved can also really keep anxiety at bay. Increasing your child's sense of control. Don't reinforce avoidance. Helping children identify their feelings. The more we can talk about what we're feeling, the more we have a schema in our mind for figuring out what to do next about it. And then when you can, don't jump in too early. Watch, wait, and wonder. Sometimes, just waiting and seeing what a child might do, you could be really surprised at what they can kind of figure out on their own. Of course, sometimes they definitely need that coaching, and you're going to need to step in, but just always keep in mind whether or not we can kind of see if we can give a little bit of space there. So, in conclusion, anxiety is common in 22q, although it's often missed. Overprotection is related to anxiety in 22q and poor adaptive functioning in those older children, and that really you guys have the biggest role in your children's development, and you can really promote the independent skills that we want them to develop, as well as decrease the development of anxiety. So I want to thank all the families who participated in our studies and who continue to. Courtney Dirtle, of course, who is amazing and did a great job with making sure everyone got here and everything was organized. And then, as this was funded by an internal grant from our CTSC, our Clinical Translational Science Center, and Tony was one of my mentors for that. So I thank him very much for his mentorship too.